Good afternoon, everybody, and it's really thrilling for me to be here. The Nothing But Nets campaign, UN Foundation, has been a terrific partner with the American Society of Tropical Medicine and Hygiene for a very long time. And it's emblematic of how we all need multiple partners, public, private sector, everyone in this fight. So it's my pleasure to introduce Lieutenant Colonel Mara Kreishman Deitrick. She's the director of the Experimental Therapeutics Branch for Infectious Disease Research at the Walter Reed Army Institute of Research, now in its 127th year conducting infectious disease research. It's the premier research facility for the Army and is located pretty nearby in Silver Spring, Maryland. She's going to talk more about the work that she does at RARE, but I'm going to tell you a little bit about her. She earned her PhD in biological chemistry at the University of Texas Southwestern Medical Center in Dallas and has been on active duty with the Army ever since. She has a whole host of awards and recognitions, which she is not going to tell you about, but I will. So I think that this is a pretty recent award. It's 11 words long. So Defense Acquisition Workforce Individual Achievement Award in Science and Technology Management. Okay. Maybe the Army can work on shorter titles for their awards. Also the Meritorious Service Medal, the Army Commendation Medal, the Army Achievement Medal. I think you get the picture. She leads the Army's program to discover and develop new drugs to protect the warfighters from battlefield health threats, and malaria is one of them. She's a leader, a scientist, a collaborator. She builds consensus. She works globally. She authors manuscripts that are submitted to scientific peer-reviewed journals. She speaks at conferences, and what's equally important, she talks with members of Congress and their staff to help them better understand malaria, how tough it is to fight malaria, and the work that RARE does to fight this awful disease that, as you all know and we've heard today, you can get over and over and over again. When she's not in the lab or in the field, you might find her at a local elementary school where she's spent more than a few years co-chairing the annual Science, Technology, Engineering, and Math Expo. She lives the excitement of science every day, and she wants kids to live that same excitement. Just like what kids in school experience, her science world has its challenges and its ups and downs. Sometimes things work, sometimes they don't, but you just keep at it, just like the search for medicines and treatment of malaria. All of us in this room, and for those of you online, we're in this fight to end malaria together, and having Lieutenant Colonel Deitrick part of this large team makes me feel just a little bit better.
Thank you, Karen, for that incredibly generous introduction. I'm actually here today on behalf of my commander, Colonel Deitrick, who really wanted to be here to give this talk, but is currently traveling in Africa, actually. So I'm here instead, and I realize I'm standing between you all and your coffee break. So I'm going to try and take a tip from Karen and be a good communicator and an interesting communicator about the work we do at RARE. Okay. And I can't quite see my slides, so this should be fun. Oh, perfect. So I've been asked to talk about a few different things. First is sort of the historical impact that malaria has had on the U.S. military. It's really been a problem for the U.S. military since the U.S. military was stood up during the Revolution, and I'll talk more about that. And then, of course, to talk about all that RARE has contributed over the years to the fight against malaria. We've been working in drugs, vaccines, biologics, diagnostics, and other testing platforms for quite a long time, 127 years to be exact. And then I'm going to talk a little bit about where the DoD medical research mission is headed in the future. Our Our Army is modernizing in a way and with a speed that it has not before, and that's definitely going to impact what we can contribute and what we need to contribute in terms of research, but RARE has a very unique set of capabilities to do that, and I'll tell you about those. And then if we have time, hopefully I can take a few questions. I certainly don't need to tell this group what a problem mosquito-borne diseases are. We're all taught from very early ages to be scared of things like sharks and snakes and crocodiles, but those really aren't the animals that we should be worried about. The world's deadliest animal, as everyone in this room knows, is the mosquito. Over 700,000 deaths a year from mosquito-borne illness, and more than half of those are malaria. We've made a lot of progress, obviously, over history, but malaria is still a big problem, and that's true for our armed forces as well. So where you might think that the biggest threat to our soldiers is actual battlefield injuries, it's actually disease. And so throughout history and to this day, disease remains the biggest cause of pulling our soldiers out of the fight. That became the clearest. As I said, it's been a problem throughout our history, but one of the clearest quotes that we like to continue to use is from General MacArthur in the Pacific Theater in World War II. And to paraphrase, he basically said that, you know, he was speaking to his physician at the time and said, "Doc, this is going to be a very long war. For every division I have in the fight, I have one in the hospital and one recovering from malaria." So it can literally decimate a force and really make us completely ineffective in terms of fighting our nation's wars. This is a map we're all very familiar with. This is a recent CDC Malaria Threat Map, looking, of course, at where malaria is endemic. Central and South America, of course, Sub-Saharan Africa, and throughout Asia. But what I'm going to point out to the group is this is that same map overlaid with where our U.S. forces are currently deployed. The size of the blue circles corresponds to the size of the force in a given area, and these are all deployments of 50 or more personnel. So one thing I'd like to point out about this map is what's actually not shown there, and that's all of those small teams and smaller groups of soldiers of less than 50 who are deployed throughout the world every day, every year. As you can imagine, those what would be little tiny dots of less than 50 folks would be spread throughout these red and yellow areas of this map. And so we do an assessment every couple years of our infectious disease threats, and malaria from the very beginning has been a tier 1 threat, and it remains that way to this day. So now I'm going to talk a little bit more about the history. That's our current situation. This furry monster in the middle of this slide is from 1788 in a British journal, and that's the monster of fever. So folks have been dealing with febrile illness for centuries, and our military is no different. During the American Revolution, George Washington himself actually became ill with malaria at one point, and malaria actually in many ways turned the tide of that conflict. The Americans who grew up in the South were exposed to malaria every summer, whereas the British soldiers who came over to fight them were naive. And you can imagine that that had a huge impact on the British Army's ability to fight the American colonists. And that's really the U.S. Army's first engagement, really, and its first encounter with malaria all at the same time. So the chart that's on the board, and there's a lot of information here, but it really is to illustrate that throughout our nation's history and throughout our military's history, malaria has been a problem. Same as in the Revolution, the Americans in the South, of course, there was a huge malaria burden in the Civil War. And then we moved on into the World Wars, and particularly in the Pacific Theater in World War II is where we really got our first really big exposure to falciparum malaria. And then it was with Korea and Vietnam that we got a taste of what relapsing malaria was all about. And I'll talk a little bit more about Korea as we move on. Since then, lots of engagements in recent history in Africa, obviously in Afghanistan, P-Vivax is a problem. And then I'm going to talk a couple specific examples of 2 different engagements in Liberia to sort of compare and contrast how different factors in an operating environment can really impact the effects the disease has on our soldiers. So in Korea, as I said, was really the first time that Plasmodium vivax sort of reared its head for our forces. And the soldiers took their chloroquine while they were in Korea. The overall burden of disease in theater was quite low. But over 3,000 cases of vivax malaria were diagnosed and treated after the soldiers left Korea. And as you can see in that graph in the middle, this is a journal article that shows the weekly hospital admissions in 1950 and 1951. The peak in 1951 was 629 cases in 1 week. You can imagine for a stateside military treatment facility that's not usually dealing with a disease like malaria, that's a huge burden on the military health system. And so that was when the Army's research efforts really took on, in addition to the Plasmodium falciparum and blood stage malaria issue, the issue of relapsing malaria. So in Liberia, as I said, we've been to Liberia. I'm going to talk about 2 different deployments. This first one was a deployment of 225 Marines to do embassy security back in 2002, 2003. These soldiers were on Tephenoquin for prophylaxis. 36% of them were diagnosed with Plasmodium falciparum malaria. And that includes 4 that needed to be ventilated and a total of 5 that had to be admitted to the ICU. I don't know what happened to my fonts, but basic take-home message here is soldiers in sort of a normal operating environment, just left on their own to take their prophylaxis, don't always do it. And so we ended up with about a 36% rate of infection. Contrast that with the deployment to combat the Ebola outbreak in 2014. This was and still is our most successful large-scale malaria prevention campaign ever. Over 2,500 troops deployed to Liberia. None of them got malaria while they were there. And that is because not only was malaria a huge infectious disease threat, but any soldier who showed up at the clinic with a fever probably, and they couldn't figure out what it was, would have ended up in the Ebola ward. So there was huge emphasis on training, both for providers and for the soldiers. Personal protective equipment, repellents in their uniforms, bed nets, all of those things, in addition to basically across the board directly observed therapy for prophylaxis. All of which amounted to a huge rate of command discipline. So commanders were very serious about this. And as I said, no cases of falciparum malaria while in theater. So you can see what sorts of factors the military has to contend with. When the emphasis is there, the tools we have work quite well. When soldiers are appropriately focused on more urgent operational needs, malaria prophylaxis doesn't always happen as effectively. So what RARE has contributed to this is really we in the Center for Infectious Disease Research have really tried to hit malaria at every life cycle stage within the human host. We have a very robust entomology program who's working on repellents and insecticides and traps. Again, ways to put things on our uniforms and things that we can carry to keep from getting bitten in the first place. The malaria biologics branch, long history and you can see there are vaccine targets at multiple life cycle stages, long history in malaria vaccine development, including what's been the most successful malaria vaccine to date, and that's RTSS. And then my own experimental therapeutics group has been in the malaria drug business since World War II. If you have traveled to a place where malaria is endemic and taken an FDA-approved drug to prevent it, that came through our pipeline. We've been involved with with the development of 100% of those drugs, and we're very proud of that history. And as I said, we've really tried to hit every life cycle stage. We also do have some foothold in the treatment space. Right now, our lead in that area is intravenous artesunate for treatment of severe malaria. Just a quick note, because it came from my group and I'm very proud of it. You all know in 2018, the anti-malarial drug Tephenoquin was approved by the US FDA. 2 separate approvals. The Army's approval was for prophylaxis. And so what this table shows you is a comparison of Tephenoquin, which is our newest tool, with our first line our first line options, which are daily doxycycline and Malarone, or what's currently our last line option because of its boxed warning with Mefloquine. And so what you can see across the bottom there is that Tephenoquin really gives us a nice tool where we can take our pill once a week. It hits every life cycle stage of falciparum and Vivax malaria. It lowers our logistical burden, so you can look at those pill counts and compare 226 pills of doxycycline plus a full course of Primaquine for anti-relapse therapy on return versus only 56 of Tephenoquin. So not only have we made, we hope, a tool that soldiers will use more, but our logisticians like this as well. Of course, the big drawback to Tephenoquin, and part of the reason I'm still in business, is that not everyone can take it. So you all know that Primaquine and Tephenoquin cannot be taken by folks who are G6PD deficient. That affects about 2.2% of the US DoD currently. That's tens of thousands of soldiers who are unable to take this drug. And so I'll talk a little bit later in the talk about what we're doing to sort of help close those gaps. And then, of course, we can't make all these new tools without a place to test them. What RARE has, both in-house and at our overseas laboratories, is world-class network of insectaries, the biggest of which is in Silver Spring, and that's home to our controlled human malaria infection model. Thousands of humans have voluntarily been infected with malaria at our laboratory in Silver Spring. Colonel Tehan loves to tell audiences that while malaria has not been in the United States for many, many years, there's quite a high infection rate in Silver Spring, Maryland, at the headquarters of RARE. And we're very proud of this testing platform. They've executed the single largest human challenge study ever conducted on the vaccine side, and of course we can use this platform not only for our new drugs and vaccines and biologics, but for multiple partners who make use of this incredible tool. So hopefully that's given you a sense of our overall approach to how we deal with vector-borne diseases, and we call that sort of our integrated layered defense strategy. So we're surveilling, we're looking at where the threats are, we're developing treatments and prevention tools for soldiers to keep them healthy, looking at repellents, and then of course laboratory and diagnosis. So really the full spectrum of tools that one needs to keep a soldier protected from malaria. And now, transitioning a little bit, I've talked a lot about the past and what we've contributed, but to talk a bit about the future. So what I've put at the top of this slide are simply cover shots of what are now our guiding doctrinal documents. And I'm not going to give you a lesson on military doctrine and theory about multi-domain operations in 2028. But what the Army and the broader DoD have asked us to do is to shift our thinking from the way we fight currently, which is a large land war in Southwest Asia, basically, to this concept of multi-domain operations, which puts smaller units out in austere environments where we no longer have superiority across the air domain and space and cyber, where we might be contested in those places. What that means for our soldiers is they'll be out, they'll be isolated, and they may not have access to medical logistics and evacuation and communication in the short amounts of time we can get those things now. And so what we're being asked to plan for from the medical side are things like wound infections, prolonged field care. We used to be able to evacuate a soldier in an hour or two. We now have to plan for a day or multiple days potentially of a soldier staying out there in the field. And the same is true for infectious diseases. Those soldiers in that environment will still be getting bitten by mosquitoes. They'll still be in those malaria endemic areas. And so the focus for our programs at RARE, on the drug side in my group, we're looking at ways to improve on Tephenoquin, particularly to close that G6PD gap. Because what we're looking for is a tool that everybody can take, that we don't have to screen for, that we don't have to exclude people from taking. We're also looking at things like extended release drug delivery systems, implantables, injectables, things like that could extend coverage from weeks to months. And then, of course, our biologics group is very much involved with immunoprophylaxis via monoclonal antibodies, which again could give instant and months worth of coverage for these soldiers going out into these environments. And so that's the direction we're headed in the future. And so I've told you some of what RARE can do. I'll now close by giving you kind of a broader picture of how RARE is poised to address these questions. So RARE is not just a laboratory in Silver Spring, Maryland. We have a total of 26 sites across the world. As you can see, big footprints in Southeast Asia and Africa, as well as a biodefense targeted lab in Tbilisi, Georgia, and our behavioral health detachment out in Seattle, out at Fort Lewis, Joint Base Lewis-McChord. So that alone gives us a huge network of partner militaries, of other international partners with whom we can work, not just looking at surveillance of disease in those areas, but with actual cooperative work to develop products. At Silver Spring, though, we have now structured ourselves into 3 centers. So our capability sets really fall now into the Center for Infectious Disease Research, where my branch is housed. That includes viral diseases, bacterial diseases, emerging infections, and our newest branch is a diagnostics countermeasures branch. And that's partnered now with a Center for Enabling Capabilities. So that is where our veterinary services are, our clinical trials center, our pilot bioproduction facility. So all of that infrastructure that my scientists need to move a drug through the development process all exists within the Center for Enabling Capabilities. And then RARE really has 2 main research missions. I've talked to you a lot about the infectious disease mission, but our other half is the Center for Military Psychiatry and Neuroscience. This is our brain health and behavioral health arm, who also has decades of experience and a huge amount of capability in that regard. But what the centers have done for us is we're now we're a much more cohesive set of work units, and all 3 of these entities really work very well together. And what that gives us between in-house and overseas is a fully integrated research institute. Of course, this is driven in the middle by the scientists, clinicians, veterinarians. This is the research going on in the middle, but that's fed by surveillance information and other data from the field, coupled with our ability to make vaccines and biologics on site at the PBF and a clinical trial center to test them in. And that cycle then continues. So once we then develop those products, we can send them out for field testing at our field sites. And it really is a very unique research and development platform, unique not only to DoD, but we're pretty sure it's the only one like this in the world. Put another way, we can run the full gamut of development and delivery. We can identify the threats, and then we can do all of the R&D required to make countermeasures for those threats, and then use our production and other capabilities to deliver those products. And with that, I'm going to wrap up, and I'm happy to take any questions.
Hi. So speaking more to the initiative to engage not just for your active duty and veterans, but also with the civil affairs aspect where they might be implementing in those areas, how do you work against the stigmatization of taking a regular medication or even engaging that mistrust, because they could assume that you're there to help, you're saying I'm giving you medications,
Right.
but they don't want to use it because they don't want to be guinea pigs.
So we do get some of that. Certainly our overseas laboratories have been huge in that regard in engaging with the communities in which they work. That's a little bit different, obviously, than in a combat zone, but it really boils down to building relationships. And that would be true of medical personnel who deploy in a conflict zone. It is a challenge, particularly in conflict where we're not on the same side necessarily. But in general, I think it's been pretty successful. But the overseas labs are far and away the best example I've ever seen of community engagement like that.
Hello. Yeah, there we go. Okay. Does RARE also do research on like CRISPR and gene drives for, I guess, like eradication of the species itself, which was always presented as a potential option for not just eradicating malaria, but a lot of mosquito-borne diseases? And also, if so, how far away is that?
I think our entomology group is just starting to move into that space. Eradication of the mosquito has not really been a focus typically, but I think obviously many in the field are moving in that direction. I think we're all eager to see how far away or how close or far that is.
yeah, I just feel like it would save a lot of resources as well, so.
Yeah, and one comment I will make, not directly to answer your question, is over the years we've sort of the military research effort sort of separated from the malaria elimination effort globally for a while, and I think that's not the case anymore, because just as you said, if malaria is no longer an issue, that lets us use our R&D resources for other things that still are, and that's why I think our engagement in the broader community, our partnerships with nonprofits and all of those things have really increased and strengthened over the last few years, because for exactly that reason, everyone's resources are constrained, and we all need to find the best solution to those problems.
Thank you for the seminar, and thank you for your service. This question is not directly from me. I have been asked this question last week at the office of Senator Tommy Duckworth of the Armed Forces Committee. It's what Walter Reed needs more from the Senate to keep the fight against malaria. Is there anything else they can do?
So any decisions about funding levels are far above my own pay grade. But what I will say, and I think this is true for medical product development across the board, really sustained funding is what's important in my view. We often find ourselves in environments where funding goes up and down every other year or so, and that does not allow for a sustained research platform. So in terms of funding type resources, that would be my answer. Sustainment is probably even a more important factor than the absolute magnitude of the number. But in general, I think groups like this who can advocate for us in Congress, as Karen said, I spend a fair amount of time talking to members of Congress about what we do, not to solicit funding, but really to make sure that the rest of our government and the folks who are governing us understand who we are, what we do, and how we contribute to the broader fight. Because that could bring partners into our overseas lab network. That could bring us into a partnership with someone we hadn't seen before. So it's a lot of just keeping the word out there about what it is that we do and how we fit into the bigger picture.